Discuss the etiology, pathogenesis, clinical features, investigations, and management of beta thalassemia major, also called as Cooley's anemia. Coming to the etiology, beta thalassemias usually arise from the point mutations in or near the gene which encodes beta globin chain of hemoglobin. The beta gene cluster is located on the short arm of chromosome 11. Pathophysiology: impaired synthesis of globin chain decreases the production of hemoglobin, causing hypochromia and microcytosis. There is accumulation of unaffected globin chains since their production proceeds at a normal rate. In the presence of reduced beta chains, the excess alpha chains are unstable and precipitate, leading to damage of red blood cell membranes. This leads to intramedullary in the bone marrow and peripheral hemolysis causing anemia. Anemia leads to bone marrow hyperplasia and ineffective erythropoiesis resulting from the intramedullary destruction of the developing erythroid cells. Marked expansion of bone marrow may cause severe bony deformities, osteopenia, and pathologic fractures. Coming to the clinical features, symptoms start late in the first year of life when a fetal hemoglobin levels decline. Pallor, irritability, growth retardation, hepatosplenomegaly, jaundice develop due to severe hemolytic anemia. Anemia and hemolysis stimulate erythropoiesis, leading to excessive marrow expansion, leading to characteristic chipmunk facies, that is, frontal bossing and prominent cheek bones. 80% of untreated children die within the first 5 years of life as a result of severe anemia, high output heart failure, and infections. Repeated blood transfusions can lead to iron overload. Many patients die secondary to iron overload related cardiomyopathy or arrhythmias. Various endocrinological abnormalities such as delayed puberty, diabetes mellitus, hypoparathyroidism, and hypothyroidism can occur due to iron overload. Repeated blood transfusions can lead to transmission of viruses like HBV, HCV, and HIV. Coming to the investigations, signs of hemolysis such as anemia, increased indirect, that is unconjugated bilirubin, increased LDH, and reduced haptoglobin levels. HbA is markedly reduced and HbF is raised. Peripheral smear shows hypochromia, microcytosis, and isopoikilocytosis, teardrop cells, and target cells. Nucleated red cells are abundant, but reticulocyte count is low due to ineffective erythropoiesis. RBCs show clumped inclusion bodies representing precipitates of alpha globin within the red cells. These precipitates, also called as Heinz bodies, can be stained with a methyl violet or other supravital stains. WBC and platelet counts are normal unless hypersplenism develops. Bone marrow shows marked hypercellularity. Serum iron and transferrin saturation are increased due to high red cell turnover. The osmotic fragility test is significantly reduced. Skull X-ray shows widened diploic space and a hair on end appearance. Compression fractures of the vertebrae and marked osteoporosis are common. Coming to the management, beta thalassemia major requires regular blood transfusion to maintain hemoglobin at more than 10 gram per deciliter. Correction of anemia leads to normal growth and development. Repeated blood transfusions lead to the iron overload. Hence, iron chelating therapy should be given, that is, desferrioxamine infusion subcutaneously over 8 to 10 hours a day for 5 days a week, or a oral iron chelator, that is deferriprone. Folic acid supplements should be given to all patients because of increased requirements due to increased red cell turnover. Splenectomy for gross symptomatic splenomegaly or a hypersplenism. Allogenic bone marrow transplantation is the treatment of choice for beta thalassemia major and can cure it. Alternative forms of therapy include manipulation of globin gene expression using butyrate and gene therapy, genetic counseling, and prenatal diagnosis should be offered to affected parents. Thalassemia minor requires no treatment except genetic counseling, avoidance of inappropriate iron therapy, and close monitoring during pregnancy. Table 6.2 shows differences between beta thalassemia major and minor. Symptoms wise, thalassemia major is symptomatic and thalassemia minor is asymptomatic. Genes responsible for globin chain synthesis both are defective in thalassemia major. One is normal and one is defected in thalassemia minor. Anemia is very severe in thalassemia major and mild in thalassemia minor. Peripheral smear is very severe hypochromasia, microcytosis, and erythroblastosis seen in the thalassemia major, while mild hypochromasia and microcytosis, few target cells, and punctate basophilia seen in thalassemia minor. Hemoglobin electrophoresis, HbF elevated and HbA reduced or absent in thalassemia major, while HbA2 elevated in thalassemia minor. Parents both having thalassemia minor may give rise to a baby with thalassemia major, while one parent having thalassemia minor gives rise to baby with thalassemia minor.